So good afternoon, everybody, and thank you for being with us today. Today is February 3rd, and today we're going to be talking, we have a hot topic, it's called menopause. So yes, there is a lot of taboo around menopause and all the things that happen to a woman when later in life. And not all the time we feel comfortable talking about it and asking questions about it, but today, we are very lucky to have an expert on the topic. Is Dr. Maria Emerson. Thank you, Dr. Emerson, for being here, who I just found out that she also speaks Spanish, so we might have to do this in Spanish later on. Dr. Emerson, well, I'm going to ask her to introduce herself first and tell us a little bit about her and her story and how she got into obstetrics. And then we're going to get into the topic. Just a reminder for all of our attendees, use the chat or the Q&A icons on your screen to ask your questions. There is no such a thing as a bad question, so I'll be happy to read all your questions to Dr. Emerson. The more questions we have, the more comments, the better. I love to have an active chat. So please help us today with questions, and thank you for joining us. And thank you, Dr. Emerson, for being with us today.
Thank you so much for inviting me. I'm super excited. And I was telling Sandra, always a little anxious. So if you hear me stutter a little bit, that's the reality of me in a large group. But my name is Maria Emerson. I am an OBGYN. I'm actually the director at Montefiore Nyack. I am born and raised in New York City to immigrant parents from the Dominican Republic. I have had all of my training in New York. Went from Manhattan College in Riverdale to Einstein in the Bronx, and actually stayed in the Bronx for many, many years. I've only been with Montefiore Nyack for a year. So most of my academic years were there and my attending years were there. I have a master's in healthcare delivery leadership, and I couldn't give up one phase of GYN. So I am a generalist. I love it all. I love my teenagers. I love my women in the reproductive age. I love all of my pregnant ladies, and I certainly love my menopausal patients. And so that's a little bit about me. Yeah, let's get it started.
Okay, perfect. Thank you so much for telling us a little bit about you. And we're going to get right into action. Menopause. How do you define menopause? What's menopause?
So menopause is actually the absence of menstrual periods, and we're going to call that menses for a shorter version. But it's the absence of menses for an entire year. That's actually the definition. So when we start experiencing symptoms, which is often when somebody says, oh, I think I'm in menopause, I have the hot flushes, I can't sleep. We may not actually be menopausal, right? Because we haven't met that definition. We still may be having periods that are.
So even if you have a period here and there and it hasn't been consecutively absent for a year, you're not in menopause yet, correct?
Correct. So we start the clock. Every time you get a period again, we start the clock.
Okay.
Right? So I haven't gotten one.
Go ahead.
Sorry, I haven't gotten one since November, but I just got one in February. Right? So now we start from February.
Okay.
And now we're waiting for the year to be February. Right? That will bring us into that.
Yeah.
Match that definition.
And how do you call that a stage, where you're missing periods, but you're not in full menopause yet?
So that's called perimenopause. And actually in the recent literature, it's more the menopausal transition, which I appreciate very much. Actually, I like that terminology because it is a transition. right? It's this process that's occurring that doesn't happen, in most of us, doesn't happen from one moment to the next unless we've had a surgical menopause.
Mhm. Okay. Um, so there is perimenopause. Is there also postmenopause?
So when you're postmenopausal, you've met that definition,
Okay.
right? So any time that we're seeing, if I'm writing a note for a patient, and it's been over a year, then that note will reflect how postmenopausal we are, right? So postmenopausal 1 year, postmenopausal 2 years, right? But I can see someone in their 80s and I would still write postmenopausal 30 years,
Okay. Yeah.
right? So that state beyond that 1 year period of time, that transition.
Mhm. And at what age do we need to start to worry that we might get perimenopause?
So everybody's different. And usually what I tell my patients is, if you know when mom had it, that's our best bet, knowing a little bit more about when to anticipate it. Some families have it a little bit younger. Some families have it when they're a little bit older. And the median age for North America right now is 51.
Okay.
But periods can start to change years before. We can start seeing a lengthening of periods. Sometimes they get a little bit shorter, right? Sometimes there's spotting before you get your period. Sometimes there's a little spotting after. We can start seeing some changes. And that can occur even in someone that is actually having monthly menses still.
Mhm.
But they might explain that there's something different about them.
Are there other symptoms to look for besides changes in your menses?
Sure. There are a lot of people that have hot flushes, right? And people call it flashes. It's actually flushes. Um, and it's that temperature, it's a heat that just rises. It's usually upper body. And no, everybody else is comfortable and you are not. You are on fire. So that's certainly one of the most common things. We can start to see some vaginal dryness. It's usually in someone that is closer to that menopausal year, right? Because that comes along with some decreases in estrogen. And we can talk about estrogen because that's our sexy hormone. And this is what drops, when we go into menopause. I gave you the definition of absence for a year. But that absence comes along with the fact that our ovaries stop working, right? They no longer function the way that they did before, right? So that lack of function decreases our estrogens, and the symptoms that we feel are, many of them, we won't say all of them, but many of them are associated with that decline in estrogen function.
Mhm.
So temperature fluxes, sometimes headaches, sometimes mood swings, right? I'm a little bit more frustrated than I've ever been before.
Mm.
I'm quicker to jump at something. I have to step back and say, oh, yeah, it's true. It's a real thing. Sometimes, there are night sweats, and
Mhm.
those night sweats can lead to insomnia, right?
Mhm.
Because you're hot and you're cold and you're hot and you're cold and you can't get any rest. So
Mhm.
there's some of the other very common symptoms.
What about dreams?
That's an interesting question. Uh,
I'm just thinking, if you're hot and cold and sweaty and this and that, maybe you have weird dreams too.
Yeah, I don't know that I've had that association
Okay.
brought up in anything that I've read.
Okay. Good
But
to know.
that's an interesting point. I mean, there certainly is disturbance in sleep at times, right? So you can anticipate that maybe there would be less REM sleep, or and right now offhand, I was telling Sandra on post call, I was on the labor floor all last night, but but so I can't remember some things, um but I don't remember what stage you actually dream in, whether you're in REM or deep sleep.
Huh?
But I imagine that there are definitely disturbances that could lead to
In the sleep. Okay. Michelle is asking, what about weight gain? Any metabolism changes? I've heard also of changes in your bone structure, calcium absorption.
So not in perimenopause, right? But once we enter menopause, I mentioned estrogen as the sexy hormone, right? So, but it's not just sexuality. Estrogen protects our bones, right? And estrogen is responsible for, in a lot of papers, and I was a part of a study when I was in medical school, where estrogen was really affiliated with a protective nature for your heart. So, we started looking at why young women, we never saw young women having heart attacks, right? You always saw them after menopause, the majority. It's a rare woman in her 30s and her 40s that's going to have heart disease. And so, but you start to see that after menopause, we actually do reach the risk that men have at certain age, like we start to climb up. And so the question was, is that associated with that drop in estrogen? And I think that there is still support for that. So yes, I mean, there are those things. And the question was about weight. And a lot of the time, there's a harder time losing weight once we hit menopause. Right? My patients always complain of that. I haven't changed my exercise regimen, right? I haven't changed what I eat, and I'm a healthy eater. And all of a sudden you can't see my waist, but I have the tire. You know, the tire, I've lost my waist, right? And my patients come in and it's not a common conversation that I bring up. It's the conversation that comes into the room. Where did this tire come from? I didn't have this before. And then we start talking about what's been happening with your periods, or since when have they been gone? And truthfully, to answer that question, yes, you do see a change in metabolism, and you do see a change in the fat distribution. So that is a definite.
So, I have that health care provider mindset where we want to fix it all, right? So if all these changes are happening because there is lack of estrogen, can we take some form of estrogen in order to help with the symptoms and the weight gain and all of that?
Right. So that was the thought, right? And back in and we're talking about from the 1990 to maybe 1992, actually 94. Let's see. There was estrogen replacement was huge, because you're not alone in that thought process, right? Replace what you're missing. Right. The problem is that we're really not designed to have estrogen for longer periods of time, right? Naturally, we are designed to have a reproductive age that is blank amount of time. So let's say, that's from age, let's average it out from age 12 to age 50. And that's our normal reproductive age. If you look at with pauses for pregnancies, right? This is the natural sort of course of events. Now, and with pauses for breastfeeding, because our estrogens are lower during that period of time, right? So that's the way our body is designed. If you look at women who either have not had children, right, and therefore have higher exposure to estrogen, right, you'll see that they're at higher risk for breast cancer, at higher risk for endometrial cancers, right? So it doesn't come along with all of the positives. Yes, there are tons of positives. If I give somebody estrogen and they're suffering with hot flushes, chances are that we're going to fix that. Right. The problem is that, we were talking before this started about sort of making decisions and doing and looking at the positives and the negatives of that. Right. So in medicine, nothing is ever all positive. Nothing is ever all negative. Right. We have to see how that weighs in for you. So because of the problems that they encountered with estrogen, it's actually fallen out of favor. It's not, for instance, it's not my first go-to for my patients.
Mhm.
right? Because I know that I'm increasing their risks for breast cancer, even if it's not a lot, because the risk is not a huge risk.
Mhm.
But even if you're increasing that by a small amount, you know,
Yeah. And I guess if you have family history, it's the chances are even greater that you're
absolutely,
gonna increase the risk.
absolutely.
Mhm.
Then the risk is so much higher that I'm not sure that the benefits that only estrogen could provide for you would be worth it, right? Because there are other treatment options.
Mhm. Now, Virginia is asking, at what age is, I guess, too young for going into menopause?
That's a good question too. So anybody going into menopause under 45 is usually on the early side. All right, so premature menopause. I recently had someone that's 36 go into premature ovarian failure and into menopause.
Mhm.
And, you know, she didn't know it, but her family actually has that history.
Mm.
So patients like that, for instance, it would be great for them to know that so that they can plan their families appropriately. But on the note that we were touching upon before, right, if somebody has a shortened cycle, right, so this is a shortened reproductive cycle if they've had premature ovarian failure, giving them a low dose oral contraceptive, for example, that includes some estrogen and some progesterone is probably a great idea, because that patient who has gone into early menopause now is going to encounter the bone loss, may encounter the vaginal dryness, right? May encounter the increased risk in cardiovascular health. So that particular patient, you're not really increasing that risk for, because you're just lengthening it to the right amount of time, hopefully.
Mhm.
Again, you would have to assess that person for their personal risks and their family risks, but it's usually a way to go.
Mhm. I'm under the impression, I think I read this somewhere, that when you start your periods, like how do you call it, your first period, earlier in life, your menarche, like then you're gonna also hit menopause earlier. Like if you have your first period later, then you get into menopause later. Is that the case? No.
It
Hmm.
sounds good, doesn't
It sounds good. Yeah.
it? It's really not the case,
No
though.
hope anywhere.
It's really not the case.
Oh.
Those patients who start earlier sometimes just have a longer, reproductive period.
Mhm.
I haven't found that. I really haven't. So the most, and we touched upon it before, but the closest thing that you have to knowing your age for menopause is not your start of menses, but actually when did mom and when did my sisters do this? If
Mhm.
you have that information.
Mhm. Okay, so it's more like family history guided. Mhm. Now, let me ask you something else. Once you hit menopause, you're not having your period or anything like that. So should you stop contraceptives as well, or you still need to keep them for a little bit? Like, what are the chances that you get pregnant? I mean, especially nowadays, you're hearing the news like 70-year-old woman is pregnant. You will think, what's going on?
So 70-year-old woman is pregnant with some borrowed eggs.
Ah,
That's odd.
okay.
But yeah, as long as your period has been gone for a year and we meet that definition, then we're clear,
Mhm.
right? Because now the ovarian function has gone away.
Okay.
Ovarian function, right? That estrogen that we produce is really your body trying to get itself to ovulate,
Mhm.
right? So once it stops doing that, once it's no longer able to sort of generate, we're born with all the eggs we're gonna make our entire lives. We're born with them that
Oh.
way.
So it's not like you're gonna make eggs as you go. That's what I always thought.
Make anymore.
Wow.
This is actually what determines what that reproductive life is. Okay. So if we came into this world with, X number of eggs, then we would have X number of menstrual periods before menopause. So when we can no longer produce any eggs, right, then it's done. Right? So if you have no period for a year, there are no eggs. Right? So we can't ovulate, we can't release them, we won't get pregnant. That's our safety net.
Okay, so wait a minute. So I guess then the more pregnancies you have, the later on you're gonna get into menopause, because I mean, you said it, we pause every time we're pregnant or lactating. Yeah. And if it's the same number of eggs, then we're kind of saving those eggs, right?
Great questions, but not all of those eggs will actually reach maturity. So yeah. So it's a great question though. It's fabulous. But when every month, right, as your body tries to ovulate, it recruits several eggs and only one of those will mature. So we don't only release that one egg. We actually use up a couple to release that one. Does that make sense?
Yeah.
Yeah.
I'm just trying to get
it was a great question.
I'm not waiting here. Okay. Liana is asking, what is the relationship with menopause and cardiovascular health issues? Is it due to the decrease in estrogen or is it something else?
That's a great question too. So a lot has been, a lot of research has been done in that area, and to date, estrogen is thought to be protective. So yes, its decline can be associated with cardiovascular health. But even if I was just talking about menopause alone, it's not just due to estrogen, right? There are a lot of other factors that contribute to all of the symptoms that we feel that are not just a drop in estrogen. The majority of it is because of the drop in estrogen. And we could say the same thing about cardiovascular health, but there certainly are other things that contribute to it.
Okay. And Teresa is asking, what do you do when your chin starts getting hair growing because of menopause?
Well, that one is, we're plucking away. We can't get rid of them. So in the sense of, just vanishing them, we have to either, laser them, pluck them, use the depilatory kind of creams, right? But unfortunately, estrogen keeps this at bay. And testosterone doesn't decrease when we go into menopause, and testosterone will cause this. Right. So
so can we take something to make testosterone decrease so that it kind of levels with the lack of estrogen?
To decrease. Because it's the last sexy hormone. Right. And a lot of women really complain about sort of having that loss of libido and loss of interest. So we don't really want to take it away.
No. If it's the last sexy hormone, no. And Michelle is asking, what leaves first, the estrogen or the eggs?
What leaves first?
Yeah, I guess what.
So in order for you to produce your estrogens, you have to be able to, like, your body, okay, your brain sends a message to your ovary. Your ovary then sends estrogen. That's the first message that it will send to your uterus, right? And that it does by recruiting those follicles that we spoke about, right? So if there are no follicles to recruit, right, your brain is going to be increasing its message because it's trying to get the ovary to fire, right? But if there are no eggs, I think they kind of go hand in hand, to answer your question, right? Because if there are no eggs, there's not going to be enough estrogen, right? So even though the message from your brain, which is called FSH, and it's one of the ways that we can determine whether a patient is actually sort of entering this phase of menopause or in menopause, right? If this message gets loud enough, and I usually tell my patients, it's like, the first time you want somebody to do something, you say it very nicely, right?
Mhm.
I usually say it about the kids, right? Please pick up what's on the floor. And you say it very sweetly. And then the second time, you kind of say, oh, that's still there. Please pick up what's on the floor, right? And the third time, it may get elevated. And so the brain does the same thing. It sends the message very nicely, very slowly. And a very well-behaved ovary who is still functioning very well will listen with a very small voice, almost a whisper, right? And it will do what it needs to do. By the time we hit menopause, it's a yell. We're yelling, please work. And nothing's happening.
Mm.
Does
Yeah.
that make sense?
That makes sense. So Kevra is asking, can menopause cause depression? I will say yes, I'm feeling depressed already. But you have the expert answer.
Yeah. It doesn't generally throw you into a major depression, but there are such mood swings and there's so much that sort of comes along with it. If we talk about weight, right? We just said that there could be potential weight gain, right? And you're putting all the effort in and you're not getting the same return on that, right? So can that make you feel lousy? Yes. You're not sleeping. You may be up at night, hot and cold, hot and cold. Of course, sleep disturbances have been linked to mood disorders, right?
Mhm.
So absolutely. In that sense, I don't think that it's a major cause of major depression, that you're going to find it on a list and say that menopause is the cause of major depression. But I think that there were so many contributing things that you can certainly fall into that sort of depressive mood, right?
And Dr. Emerson, Kevra, actually, I think she's reading my mind. Do men have similar charges? I know you're not a male doctor, you're a women's health care provider, but come on. Do men suffer anything like this?
Okay, so what I
I'm gonna
know
change
on
the
a
word
clinical
suffer.
level,
Go through.
they don't go through the same thing. There is a slight decline in their hormone production, but it really doesn't cause the same thing.
Mhm.
So, it's part of the issue that I deal with some of my patients is the fact that, the partner that they're with, even if they're the same age or they're a little older, they really haven't lost their libido. And my patients are not all that interested right now, either because it's, painful or because, her because her estrogen, I'm sorry, I just got a message of somebody watching the webinar. So, and so, and I lost my train of thought because that happened.
Men.
Yes. And so they may actually not change, their interest in sexuality, but my patient may be like, wow, I'm not really there. Right. So their hormones do drop a bit, but not enough to match.
Mhm.
Right? So part of the issue that that we address in my office with patients with menopause is really that maybe it takes more effort. That kiss on the neck that used to do the trick may not be all of it, right? In the morning, we have to start thinking, maybe today is, maybe today is a good day for this. I'm going to put on some wonderful music. I'm going to start using my brain to feel sexy. I'm going to put on some sexy clothes, right? And those things are going to now play a part in the imagery that's going to lead to the events of later, but it isn't going to be that easy anymore.
Mm.
Right?
Okay.
And our partner needs to be made aware of that as well. Right? It's not that easy. It's not that I'm not interested, which I think a lot of men sometimes feel. Right? Oh, you're not interested anymore. What happened? You don't like me?
Yeah.
Right. So
Okay.
there's a lot that goes into this. There's so much.
So we definitely need to do another community chat for males to know how to, I don't know how you say it, like
To educate?
educate on how to treat a woman,
Yes.
right, who's going through menopause.
Yes, spice it up. Yes.
I love, you know what? I'm writing it down because I love that name for another community chat. Spice it up for men. Spice it up for men.
Spice it up for your, but it's for your partner, you know?
For your partner. Yeah, exactly. I think we need to talk about that. Okay, so there is nothing we can do to prevent any of the changes. So what can we do going forward? Is there any exercise, any changes in diet, anything we can drink, do, travel somewhere? I don't know. What do you recommend so that we keep the sexy?
Okay. So a couple of things. It's not that we can't do anything at all, right? So you hit on a couple of points. Exercise, certainly one of the things. There are some articles that will tell you that exercise will help with hot flushes. The recent ACOG bulletin says that exercise doesn't help, but my 22 years of working with women in menopause, I can tell you that the women that exercise actually feel better, right? Whether it's because of their release of endorphins, whatever it is, they're actually doing well and doing better. I think the other thing that we didn't touch upon, we mentioned the estrogens and sort of the steering away from estrogens, but we didn't talk about other treatments, right? Sometimes, and this is going to tie in a little bit of the depression talk that we talked about, and the fact that estrogen isn't the only contributor to how we feel in menopause and the symptoms that come into it, but it's really a small antidepressant, a small amount of antidepressant has been shown and is FDA approved for treating hot flushes in menopause. And it's worked really nicely in a lot of my patients. And it's not because they're depressed. It's because there are components that affect our mental health that, like epinephrine and norepinephrines, right? That also contribute to these hot flushes and these temperature fluxes that we feel. So that's part of it. And we hadn't touched on that. So I just wanted to make sure that we did that. And there, if the symptoms are solely vaginal, that replacement doesn't carry the same risk. So we can replace estrogen there because it doesn't get absorbed as well. So for instance, right, I have menopause comes along with a thinning of the vaginal mucosa, right? A lack of sort of that stretchability. Okay. Right, that elasticity, and that gets lost in the process. So oftentimes the complaint is really, I'm having pain, and it's because we can't accommodate, right? And so what happens when we try is that you get tears instead, almost like paper cuts, right? This is painful. Nobody wants to do that, right? You touch something hot, you know not to touch it again. Something hurts you, you're not going to do it. Right. So, but here we can replace what's missing because vaginal estrogens don't get absorbed really well. Right. So we're not increasing the risk for for thromboembolic events or clot formations. We're not increasing, which is something that estrogen is associated with, and we're not increasing the risk of breast cancer. So this is something that we can do to keep the sexy.
Mm-hmm. So this vaginal estrogen, that's topical, that's not oral, right?
It's not oral, you use it vaginally. And there are many forms. There are creams and suppositories and rings. Mm-hmm. So there are ways to distribute this that, many different women can find it comfortable. Some of us don't like creams, some of us don't like suppositories, right? So there are different ways of distributing it. And that will keep the vaginal tissue healthy.
What about the dryness? You mentioned dryness is also an issue.
Yeah, that comes along with it. So if for instance, we're at a point where it's just dryness, but you don't feel pain necessarily, then maybe lubricant is all that we need. Mm-hmm. Right? There are creams that provide sort of moisture to the area. If we're not, even if we're not talking about sexuality here, right? If we're talking about just the feeling of irritation and discomfort, sometimes itching, right? There are moisturizers that can be used that even out your pH, that will provide the moisture that's missing when when these glands are stop producing the amount of lubricant that we normally produce.
Mhm. And going back to talk about exercise, Dr. Emerson, Michelle is asking if weight-bearing exercise is okay, or what type of exercise is best.
Yeah, so weight-bearing exercises are always going to be great because one of the things that occur after menopause is osteoporosis, right? So weight-bearing exercises are going to help us fight that. So absolutely. I think, maintaining some cardiovascular health, right? Because we talked about how our cardiovascular health can be affected also. So cardio is great. Any type of exercise that will allow you to maintain, a healthy, um, a healthy self and keep the weight off, right? I think would help. And I'm just going to go back a little bit because we some of the things that we can do we didn't touch on. So layering clothes, right? So that you're able to change out of things, take a sweater off, have cool drinks with you, right? Things that will allow you to keep the temperature lower. Maybe you don't have to keep the temperature at 71, right? And so those things are helpful and really sort of the easy things to do initially and see if those things work out.
Mhm. Now, I think that this is a natural process, and as women, if we're lucky to get there, because really we're going to have a long, healthy life, and we're all going to get there one way or another, sooner or later. How can we have this conversation with our OBGYN, with our partners, with our children? Our bodies are changing, and I feel that there is a lot of taboo around it, like we don't feel comfortable talking about that. So how do you initiate that conversation so that people know to be patient in a way with us, patient in bed, patient with our mood, with our, what you were saying, with our children, things like that? How?
Yeah, so I think it's really just about being understanding the process for yourself and then being able to say, I'm, I'm sorry if I answered that way, or let me step back a little bit before I answer you because I'm easily frustrated right this second. I use the example of me being post call. I'm often a little bit edgy when I'm post call, right? And I will always tell my kids, just remember I'm post call. If everything is, if it's louder than it needs to be, right? Or they're harping on something, I'll say, just remember that I'm post call. I'll get to you, don't worry, but just try to bring it down just a notch. And I think that they understand that. And as now they'll do it for themselves. They'll do it. If they hear me answer a certain way, they'll be like, oh, mom, you're post call.
Mm-hmm.
Right? Because I accept it as it's something that I'm doing. Right. And I think as long as you're understanding how you're affected by it, or I didn't sleep last night, right? I find myself so irritable. Those noises are so loud, right? Or is everybody okay wearing a sweatshirt? I need to take the temperature down a bit,
Mm-hmm.
right?
Mm-hmm.
And I think that I think that helps. I really do. I think just
As you're talking, I think that one way or another, as human beings, we're all afraid of getting older. And if we, I think it's easier to say I'm post-call, that I'm getting older and I'm going through menopause. And this is why I'm so irritable, because I'm already thinking the reaction is going to be like, oh, you're so old. We don't want to hear that. Right?
I don't know. I think it's an interesting thing. And I don't know that anything that I know as a physician um, is going to enlighten what we've done in our communities to getting old. But it's actually, I wouldn't give my years of experience for anything,
Mm-hmm.
even my youth, even my young body. Right. And I think that that's in so many cultures, that's so well respected. And I think we've lost sight of that.
Mm-hmm.
And I don't think that has anything to do with medicine for me. It really just has to do with, the way that we treat somebody that's aging, the mature community. It's not okay to get the AARP magazine. Look at what I got,
Yeah, exactly.
right?
Yeah. Mm-hmm.
There might be some interesting articles there, actually, but it's offensive.
It is. It is.
But I think that's really a cultural thing.
It is.
I think, if we become a little bit more comfortable with it, there was nothing in, I come from a different background. And for us, the matriarch of the family was the grandmother. Nobody knew more than your grandmother. Like that was it. That was the height of things,
Mm-hmm. Yeah,
Uh,
I think what you're saying is great. Like we need to learn to accept ourselves and the beauty that comes with this next stage, as opposed to looking at it as downhill. It's just like a new beautiful stage in life.
right. And maybe it's time for you, right? How many women are notorious for dedicating their lives to everybody except themselves, right?
Mm-hmm.
Everybody has an appointment at the right time. Their kids have an appointment at the right time. The dogs go to the vet. The husband has the appointment. Even their parents go to the dentist. They've made everything. They're the last ones that get taken care of. So maybe it's time for you. The kids are out, right?
Mm-hmm.
And it's okay to look at it that way. And it's okay that you have a couple of grays. See?
Yeah.
And it's okay that, yes, and it's okay. And you're still sexy if you want to be.
Mm-hmm.
And it's okay if you don't want to be too. Right? Like there's,
True.
yeah, like that you have sort of that comfort of being who you are, and it's okay. I think when we're young, we have so many insecurities that haven't really, that we really haven't come to terms with. But I think by the time a woman is going through menopause, there's a lot of assurance about who she is, and
Mm-hmm.
and what she's done, and how either happy she is with what she's accomplished, or things that she might have in mind that she might want to do now that she has time. Right. So I think if we just look at it that way, it's a very different view.
Yeah. Yeah, I absolutely agree. I think that we need to, now that we're changing physically, mentally also, we need to put ourselves in a better place and look at the advantages of menopause.
And there's plenty. Nobody wants to bleed every month.
Mm-hmm.
Right. There's something to be said about that. Right. And how many women suffer through with horrible menses,
Mm-hmm.
and horrible migraines that have been affiliated with their menstrual periods. Right. Those things go away. Right. The breast tenderness that didn't let you lie down on your back, on your, tummy the way you wanted to sleep. Those go away.
Mm-hmm. The red light.
The red light.
Right? Like, oh, red light.
That's right.
No more red lights, only green lights.
That's right.
Mm-hmm. Are there any other advantages to menopause? I just would like to end on a positive note here.
I mean, I think we touched upon some of them, right? Let's see. I don't know. I mean, I think we did touch on the majority of them. I'm post call, Sandra.
I get it. Okay, Dr. Emerson, it's hard sometimes to find an OBGYN that we feel comfortable with.
Mhm.
And especially when we're going through these stages in life again. So what are good characteristics of a good OBGYN? How do we know this is the right doctor for us?
I mean, that's a harder one without meeting someone, right? But you want somebody that's personable and that's going to be able to talk to you, right? Because sometimes if you're just there because you need a pap and this is the rush job that's being done, right? Then this doesn't allow the moment for you to open up, because sometimes it takes a second for you to say, oh, I really should bring that up, right? I experienced such and such thing, and I should say something. But if somebody doesn't give you the time to talk, right, then that's not useful. So I think you just need someone that's willing to give a little bit of time, and screen,
Mhm.
right? Because I do screen. Are you sexually active? I don't care if you're 80.
Right.
You're getting the same question in my room,
Mhm.
right? Are you sexually active? And is that painful for you? Is
Mhm.
there any discomfort that comes along with that? Because that opens up the door, you know?
Mhm. And I just wanted to make sure that Kebra got her question answered. She was talking about any natural remedies for all the menopause symptoms. I think you touched a little bit on that as well, like lowering the temperature, keeping out
Probably
cold,
means more like herbal things.
or maybe herbal. Mhm.
Yeah, so there's acupuncture has been used to help with some symptoms. Um, Black cohosh has been used. None of these things are FDA approved, unfortunately, um, because they don't measure the amount of, they usually have natural estrogens in them. That's how they work.
Mm,
And because these things are not FDA approved, these products are not FDA approved, we never know what level you're getting,
mhm.
right? It's not a standardized dose. And for those, even those women that actually do end up on hormone replacement, we do try to put them on the lowest dose possible for the shortest period of time, right? So a lot of these natural products don't have that measure for us to do. But there are a lot of people that will swear by the black cohosh, you know, and that have had acupuncture and feel so much better as a result. There are some Chinese herbs, and right now, Dong Quai, I think is the name of it, that have also been sort of word out that these are things that we can do. I usually tell my patients to do some dietary changes, and you probably know a lot about this more than I do, but some of my favorite things are including some foods on days that you're really uncomfortable, including some foods that may have some natural estrogens like yams, lentils, soy products, right? Um, and some of the studies that have been done on different cultures and women going through menopause in different cultures have shown that women in Asian cultures actually have less hot flushes. So the question has come into play, is it because they consume so many soy products that have natural estrogens?
Oh, look at that.
It's an interesting thing. It's an interesting point, right?
Yeah.
Yeah. So there are natural things that people try. Most doctors aren't willing to put a stamp of approval on them because they're not FDA approved.
Mhm. Oh, well, we can try it and see what happens. We'll let you know. We'll be the guinea pigs. Okay. I want to just say thank you, Dr. Emerson. This was a very interesting conversation. And you were saying that you have two practices here in Rockland, correct?
I do. I'm part of Highland Medical, and we have two offices. We have one in New City and the other one at Stony Point.
Okay. Yeah, that's great. I said I'm gonna be looking for you.
You're lovely. Thank you. I'm so excited that everybody participated so much. This was wonderful.
Yeah, it's great. I have a great audience. I couldn't love them less because, you know, they make my job so much easier with all their questions, and they're all good questions. So
Fabulous.
I told you were going to like it. So
Thank
thank
you
you,
so much.
Dr. Emerson, and thank you to all of our participants today. I hope we answered your questions. If you have more questions, just let us know. You know, you have my email. Always send us an email. We're here to provide you with any education that we can and answer all your questions. So I will see you next week. Next week, let me see, we're going to be talking about, oh, actually next week is going to be all on nutrition. And we're going to have a registered dietitian doing a live cook demo because we don't want to spend a lot of time in the kitchen. So she's going to be giving us tips on how to do very quick, healthy meals. So that we don't spend more than 20 minutes in the kitchen cooking. So that's going to be very interesting. And I'll see you next week. Thank you all for participating today. Dr. Emerson, see you soon.
Bye-bye. Thank you.
Take care, everyone. Bye-bye.